Awesome. Can you allow me to screen share? Okay, now this. It wasn't letting me before. All right. All right. Can you guys see that?
Yes, we can.
Great. All right, so thanks everyone for coming. My name is David Janiczek, and I am a fourth-year anesthesia resident at the University of Illinois Chicago, Department of Anesthesia, and I'm also founder of Get Admitted MD, which is a pre-med consulting company I created a few years ago to help pre-meds get into medical school, and then also medical students get into the residency of their choice. So. And then I created basically an online course to help everyone get into medical school as well. So tonight we're going to talk about a little bit about anesthesia, which you will tell is a passion of mine. So first, a little bit about myself. I was originally born and raised in Iowa. I went to the University of Iowa for undergrad and med school, then went on to residency where I'm at currently at the University of Illinois. And then I'll go down to New Orleans in the summer, where I'll start a cardiothoracic anesthesia fellowship at Ochsner Health. So tonight, let's talk about why I chose anesthesia. When I was shadowing, as a pre-med, I always kind of wanted to know why, those physicians chose the specialties that they chose. I think it gives you a lot of perspective and, a lot of information into, why you may want to be involved in that field in the future. I actually have 3 cases to go over tonight. So one, I'll talk about general anesthesia, kind of our bread and butter. I'll talk about a very popular component of the field of anesthesia called NEURAXIAL anesthesia. And then I'll talk about a subfield of anesthesia in chronic pain management. So I'll touch on a little bit about how you become an anesthesiologist, what's that path like, and then also, talk about everyone's favorite topic, which is certified registered nurse anesthetists, or basically CRNAs is how they're referred to. So first, why I chose anesthesia. So first of all, it was a fascination basically with the interaction between human physiology and pharmacology. I basically developed a love for, learning how the body works and how to manipulate the body with pharmacology. And that plays out every single day in the operating room. So it's a great environment for me. Outside of that, I just love the operating room. It's a place for some people. I understand that some folks don't like it, and that's totally fine. It's very chilly and cold typically, but I kind of enjoy that. And it's just a fast-paced, acute, setting that things happen very quickly, and you got to think on your feet a lot, which is always fun. And so I knew I wanted to go into something in the realm of the operating room. Third was the ability to do procedures. So, I knew I didn't really want to be a surgeon, but I still wanted to be able to do things with my hands. And so, anesthesiologists, we're always busy doing stuff with our hands, whether we're intubating, whether we're placing central lines, epidurals, placing IVs, all those sorts of things. We do these things very regularly. So, it kind of breaks up your day. It makes things fun and interesting. And, I think it's, a really great asset to be able to, perform these procedures, especially in emergency situations when you may need to. Fourth, just being able to work with different specialties on a daily basis. I think that's really, interesting. It keeps things fresh. One day I might be in the cardiac operating room. The next day I might be in the orthopedic operating room. And, you get to talk with different specialists and kind of, pick their brains on certain things. And it just, it's not the same thing every single day, which I think is awesome. One of the biggest things for me was, having something where my interventions would have an immediate impact on a patient. So I never wanted to be a physician who, saw a patient in clinic, told them to take this pill and come back and see me in 3 months. I don't know if they're going to take the pill. I don't know if it's going to work. I don't know if insurance is going to approve it for them. And so, when I was entering the field of medicine, I really knew I didn't want to do that. So, I know the patient's going to get the medicine because I give it to them in the operating room. And so it kind of alleviates a lot of those things that, if you're a primary care physician, for instance, you may have to deal with. And then the last one's a little controversial. The very little continuity of care could be viewed as a positive or a negative. I look at it as a positive. I think it's really nice to see, different patients every time, and we're not, seeing the same patient over and over again. Obviously, we have a couple, patients here and there that may come back for surgery multiple times in a row, and we see them a couple of days straight. But for the most part, we see a patient once and then we never see them again. And so it's one field where you're not going to develop a relationship with patients, over the long term. You're not going to develop a real relationship with patients, family members over the long term. And so if that's something that's very important to you in your career, anesthesia is maybe not the best fit for you. The one caveat to that is chronic pain management. Typically you see these patients for, months and months and, years and years even. So you can develop those relationships, but that's, kind of a subfield of anesthesia that not everyone gets to experience. All right, so let's move on to the what is anesthesia component. So we're going to start talking about general anesthesia, which is kind of what you think about when you think about surgery and anesthesia. It's kind of the Hollywood version of anesthesia. So what actually is it? So general anesthesia is really made up of 4 pillars. The first being analgesia or pain relief. Obviously, we want patients to go through surgery with as little pain as possible. It's almost impossible to have zero pain. But as little pain as possible, that's our goal. So that's definitely a pillar. Paralysis or muscle relaxation. Many surgeries, we don't need to paralyze the patient. However, sometimes we do. And so, we can use drugs to basically, inject in their bloodstream and kind of doesn't really make their muscles work, basically. So it's not necessarily paralysis, it's more like a muscle relaxation. And so, we can obviously reverse that at the end of the surgery. And like I said, it's not used for every surgery. And there's certain instances where we do, kind of need to use it, but that is one pillar. Amnesia is a loss of memory. So we don't want patients to kind of know, what it was like to roll into the operating room. That can be a very scary experience for patients. There's a lot of lights, there's a lot of equipment, a lot of people. And so we can give them a medicine ahead of time to basically block their memory for a few hours. And that way they don't remember any of that. And then lastly, unconsciousness. This one's a no-brainer. We want the patient to be unconscious for the surgery. So there's a whole host of medicines we can use to accomplish this. But there's good and bad to each one of those. So we kind of choose it based on each patient. And so at the bottom of the screen here, you see a spectrum. So on the far left, you have the awake state. On the far right, you have the asleep state. So on the awake side, we have what's called local anesthesia, neuraxial anesthesia, and regional anesthesia. So local anesthesia, if you guys have ever been to the dentist and they injected some medicine in your gums or in your mouth and it numbed up a small area, that's local anesthesia. It doesn't really make you go to sleep at all. It just really is numbing up a specific area. Regional anesthesia, on the other hand, is numbing up basically a larger area of your body. So let's say, you're having shoulder surgery. So if you're having shoulder surgery, you want definitely, your shoulder to be covered in terms of, you want it to be numb for surgery. You want it to be, pain-free, everything like that. So we can actually numb up your shoulder and your arm. And we can do that with what's called a nerve block. And that's also called regional anesthesia. And then neuraxial anesthesia, which I'll talk about a little bit later. Basically, that's, epidurals are kind of the classic thinking there. So, most people think about epidurals in terms of labor. However, we can use them for other types of surgery as well. And so that falls under the classification of neuraxial anesthesia. In the middle, we have the sedated state. And so this is used for, small surgeries that, can't really be done under local anesthesia or neuraxial or regional, but they don't need general anesthesia, which is all the way off of sleep. So sedation is also referred to as twilight sleep, if you guys have ever heard that. Basically, we give patients a little bit of IV medicine. They get put in this twilight sleep, and the surgeons or proceduralists can do their procedure, and then we basically, wake the patient back up and they're done. It's really great for short procedures. It's really great for, procedures, maybe involving, the skin or something that's not very deep in the body, and the patient doesn't need to undergo general anesthesia. So the last, all the way on to the right of this slide is what's called general anesthesia. So that's what you classically think about in terms of anesthesia, where you're all the way off asleep, breathing tube, the whole 9 yards. You may see someone, an anesthesia provider like this, holding a mask over your face before you go off to sleep. That's typically general anesthesia. So this is where, we kind of have these 4 pillars come into play. Like I said, you don't need all 4 every single time. So most of the time, the one that's not there is the paralysis. But, you can, the other 3 are pretty, necessary. You can also divide anesthesia into kind of 3 phases if you think about it more on a case level. So the first phase is induction, and there's a lot of parallels between anesthesia and the airline industry. So induction is like taking off. There's a lot of things that can go wrong. It's very tedious. There's checklists you do before you before you take off. There's checklists you do before you basically put a patient asleep, and so essentially this is like I said, a very tedious time, a very tenuous time, and you need full vigilance to make sure everything goes smoothly. After this phase, you're in the maintenance phase. So this is when you're up on cruising, you're on autopilot. There's minor things that go wrong, but for the most part everything goes very smoothly. And so, at this point, you're just, you're monitoring the patient, you're watching their vital signs, you're giving them medicines if they need it, for pain or for blood pressure, or, redosing the muscle relaxation, everything like that kind of happens during the maintenance phase. And then emergence is like the landing. So once again, very tedious, very tenuous. A lot of things can go wrong when a patient wakes up. It takes very quick amount of time to get the patient off of sleep. Waking them up takes much longer. So you kind of have to plan it out, just like, when someone's landing a plane, they have to plan it out and be on the right approach and everything like that. And so if you think about anesthesia in these terms, you kind of, get a framework for how anesthesiologists think throughout a surgery. All right, so let's jump into a case. This is a pretty straightforward case that we would see, on a daily basis. So we have a 19-year-old male. He's 75 kilograms. His BMI is 24. His HPI, or history of present illness, he had sharp abdominal pain that started 2 days ago near the umbilicus or belly button, and now is in the right lower quadrant. He's now, nauseous and vomiting, and he's got a fever up to 102 degrees Fahrenheit. Past medical history of PMH, childhood asthma, but no longer takes inhalers. It seems well controlled. Doesn't have any issues with breathing currently. Unknown surgical history. Family history, he's got diabetes, hypertension in his father, high cholesterol or hyperlipidemia in his mother, and a little bit of obesity. Social history wise, he doesn't drink. He does smoke marijuana, but he denies any other drug use such as cocaine or heroin or PCP or LSD or any of the crazy drugs. So what other information do we want to know? And so basically we go see the patient after we, find this information in the chart. And so, we want to ask a few more questions, any previous anesthesia, if so, any complications, is usually one of the first questions we ask. And so basically what we're looking for there is to find out if they've ever had problems that we could then prevent for this, this surgery. So one big issue with anesthesia is nausea and vomiting after surgery. So if the patient's had a history of nausea and vomiting, we can take steps to help prevent that for this one, and make their experience a little bit better than maybe it was last time. We also want to know if there's any family history of problems with anesthesia. There's one big complication of anesthesia called malignant hyperthermia that can happen. It does run in families. That's why we ask if there's a family history of it. And it really just, it can cause high fevers after surgery, muscle rigidity, and can lead to death. And so it's kind of a big deal if a family has it. But most of the time, if one family member has it, the whole family is kind of on high alert from it. And so, they typically know. So if you don't know if your family has it, you probably don't, because most of the time it's pretty commonly spread information among families that do have it. The next question is, any allergies to medicine? Obviously we don't want to give a medicine that the patient's allergic to and cause an allergic reaction in the operating room. And so we want to just verify all their allergies. We also want to know the last time they ate or drank anything, or the last PO intake. So, this becomes really important for anesthesiologists, because we don't want anything in the stomach that can potentially come up through the esophagus and then go back into the lungs. That's called aspiration. So there's kind of a couple times that this can happen. So when we're placing the breathing tube, you can have aspiration, and then also when we take the breathing tube out, you can also have aspiration. And so, any sort of food in the stomach is a risk for that. And so we have to take extra precautions. There's actually guidelines out there that say, if you've had a steak dinner, you need to wait, or you should wait a certain number of hours before having anesthesia, versus, if you had a sip of water, that time frame is different. And then lastly, we do a quick review of systems. So we essentially go head to toe, make sure there's nothing we're missing, basically organ system by organ system. So, the brain, the heart, the lungs, the kidneys, make sure there's just nothing that we need to be, cognizant about before we put this patient off asleep. So, we have all this information. And so, how do we examine the patient from the anesthesia perspective? So different from many other fields of medicine, one big thing that we're very concerned about is the airway. This is what keeps us up at night. This is what makes us have nightmares, everything like that. So what you see here is basically how we look at a patient's airway and how we classify it. So this is called the Mallampati classification. And so basically you have 4 classes, 1 through 4. 1 is the best, 4 is the worst. And then 2 and 3 are kind of in the middle. So you can see on class 1, you have, to do this, basically you need to have the patient sitting up, looking at you, and you have them open their mouth as wide as they can, and then stick their tongue out. And so basically what we're looking for here is, can we see the uvula? Can we see these tonsillar pillars back here? How much open space essentially do we have? And so on and so forth. So class 1, you can see there's tons of open space here. You can see all of the uvula, all of the tonsillar pillars. It looks pretty good. Class 4, on the other hand, you can see is much different. So the tongue takes up like, half or 75% of this opening. We don't see any of those structures. So we don't see the uvula anymore. We don't see the tonsillar pillars. It just looks cramped. And so this is associated with a more difficult time intubating the patient, versus a class 1 is associated with an easier intubation. And so that's why it keeps us up at night, is because, we, want to get the breathing tube in when we intubate a patient, first time, every time, and make sure that the airway is secured. If we're unable to do that, that makes us, very worried. So in between class 1 and class 4 are class 2 and class 3. Sometimes there's debate. Someone may think a patient's a class 2, and someone comes back 5 minutes later and they think they're class 3. Most of the time these are interchangeable to a certain degree. It's really the 1 and 4 that we care about the most, just because if it's a class 4, we may need extra equipment or extra help to get the breathing tube in, and so we would just want to be more prepared for that. So luckily our patient is a class 1 airway. He's young, healthy, otherwise skinny individual, so class 1 airway for him. So other things we look at when we examine the patient that are kind of unique to anesthesia. So thyromental distance, or TMD. So basically this is an example of how you measure the thyromental distance. You have the patient look straight up and basically measure from the tip of the chin to the tip of the thyroid cartilage. And you can measure it in centimeters or finger breadths as well. Sometimes, physicians will report it in finger breadths. The basic idea is that the shorter that TMD is, the more worried we get in terms of trying to get a breathing tube in the patient. If it's a longer TMD, we typically have more space. We can adequately get in there and assess the airway. But it's just another tool we have to examine the airway. And then mouth opening. Obviously, if the patient can't open their mouth, it's going to make it harder to intubate them. Some reasons why they may not be able to open their mouth: if they have a fractured jaw, and that's why they're having surgery. Those patients typically have a hard time opening their mouth when they're awake due to pain. And so often when the patient's asleep, then they don't have that pain, so therefore their mouth actually opens much better. But you just have to kind of assess that on a case-by-case basis. Other things, if the patient has an oral mass or cancer, sometimes that prevents a patient from opening their mouth fully. So, we just kind of make sure that we know how much they can actually open their mouth before the operating room. Some more general things we look at, cardiac wise, we look at their heart rate and their heart rhythm. Obviously, if the heart rate is 150, we're kind of concerned about what's going on versus, if they have a nice normal heart rate. Same thing with rhythm. If their heart rhythm is, atrial fibrillation or something else, we get a little bit worried versus if it's the normal heart rhythm. We know that ahead of time. If they have any murmurs or anything like that, we can listen to their heart. Respiratory wise, we want to know what their lungs sound like before the operating room and before we intubate them. So, we generally listen to lung sounds as well. And then lastly, IV access. So the IV is kind of like, it's very important to the anesthesiologist. It's our method of giving drugs, giving fluids, giving blood if we need to. And so we want to make sure the patient has really good IV access. So if they don't, then we need to, likely put in a new IV. And so, we just want to assess that before we go back to the operating room. All right, so let's move on to how do we intubate a patient. So there's a bunch of tools on here. So I'm just going to go through one by one. Down here in the bottom center, basically is what we call a laryngoscope. So this is a kind of the classic way that we've intubated patients, for many years. This is a handle in which you basically hold in your left hand. It's a battery pack, so there's batteries inside here. And then this part is called the blade. There's not actually anything sharp there. It's just there to move the tongue out of the way. And then this little thing right here is a light, so that when we get in the mouth, we can actually see where we're going. Up in the top left corner, you can see a upgrade to this system called a video laryngoscope. And so probably in the last like 15 years or so, this has become, kind of mainstay and much more popular. So essentially what they've done is they basically just replaced this light with a camera that then gets shown on a screen here. And so we can basically see where we're going, on the video screen instead of looking in their mouth directly. This is really nice. It typically gives us a great view and we can intubate. So this is a huge, kind of advantage for intubating patients. Up here in the top right is essentially a mobile version of the video laryngoscope. It's called the McGrath laryngoscope. Essentially, you can see there's no cords, there's no cables, there's no screen on the side. It's basically just a handheld screen. So basically, the screen is much smaller. But you can, put this in your pocket and run up to the ICU if you need to intubate someone emergently, versus it takes a little bit more, time to gather one of these and then roll it into an elevator, take it upstairs with you. And so it's much more cumbersome versus, this is quick, easy, gives you a view, and you can intubate patients much quicker with this. Down here in the bottom left, you can see these are just different types of blades we have. And so there's much other, there's more types of blades in this, but basically there's curved and then there's straight. And so these curved ones are called Macintosh or Mac blades. So there's various sizes ranging from, for kids to adults. And then these are called Miller blades. So Miller blades are straight blades. Once again, they go from pediatrics or kids to adults. Honestly, it's just preference which one you use. Kids typically are intubated more with the Miller blades, but you can intubate them with the Mac blade as well. It just depends on provider preference. And then down here at the bottom right, this is a fancy tool we call a fiber optic. So basically, this is a camera that's on the end of here, and this individual can control it with their thumb. So the end of the scope basically moves around, so you can guide it past things. You can really navigate it into the airway. So it's a really nice tool we have. All right, so this is actually what it looks like when someone's intubating. So this anesthesia provider is essentially using a direct laryngoscopy technique. So basically, this is the laryngoscope in their left hand. This is the breathing tube in their right hand. They are, using the laryngoscope to basically push the tongue out of the way, and they can actually look down into the back of the oral pharynx. And then they place a breathing tube in through the mouth and then down into the trachea. As you can see from this photo, the esophagus is right next to the trachea. So you can often, when new anesthesia providers are training, they can also often, put the breathing tube in the wrong spot, and they put it in the esophagus instead of the trachea. which, if recognized, doesn't really cause them any issues. You just take it out and put it in the trachea. However, if it goes unrecognized, the patient could desaturate, or their oxygen saturation could go down, and other things can happen. So it's just really important to know where the breathing tube is, and make sure it's in the right spot. So this is what you look at if you are basically, intubating a patient. It's another grading scale we have. It's called the Cormack-Lehane grade. And so basically, once again, 1 through 4, 1 being the best, 4 being the worst. So grade 1, you can see this is the glottic opening, or basically here are the vocal cords right here. And this is where the breathing tube goes when we intubate a patient. So our goal is to get a view like this. We can guide the breathing tube right through this glottic opening, and through the vocal cords, and on the other side is the trachea. As you move to the grade 4, you can see that there's you can't see any of those structures that I talked about in this picture. You basically just see the back of the tongue. This is a very hard view to intubate with. So either you need to change your positioning, get a different tool to intubate, something needs to change so that you can get it more, close to a grade 1. Not every patient can be made a grade 1 view. So if you're, able to get a grade 2, often you can just slip the breathing tube right underneath the epiglottis, which is this floppy structure right here. And that the trachea is right behind that. Grade 3 is a little hard to intubate on, but it can be done. And so it really just depends on how experienced you are, and if you're able to, feel comfortable doing that. So luckily, our patient, once again, is a grade 1 view, young, healthy individual. This is pretty common. So now the patient's intubated, what do anesthesiologists do? It's not time for Sudoku or crossword puzzles like the rumors tell you. We need to place additional monitors, IVs if necessary. If we're going to place an arterial line, which is a special monitor to monitor your blood pressure, those things need to be done before the surgery can actually start. If the patient needs to be positioned in a different way, that needs to be done. But sometimes we can just, if the patient needs to just be on their back, then, we may not have to reposition them. We monitor the vital signs continuously. So we have a monitor in the operating room that basically gives us all the vital signs that we want. And then, we're continuously monitoring that for any changes that we see. And then, the surgery goes on. And then once the surgery is done, we have to wake the patient up. And like I said before, it takes time to wake the patient up. It doesn't just happen, once we turn off the anesthesia. It takes, 10, 15, sometimes 20 minutes to wake the patient up. So we have to kind of plan that out. To wake them up, basically, we just turn off, what we call the inhaled anesthetic. So once the breathing tube is in place, we can turn on what's called inhaled anesthetic, and that's what actually keeps you asleep during surgery. So we get you off asleep with IV medicines, and then once the breathing tube is in place, then we can give you the breathing medicines or the inhaled anesthetic to keep you asleep. If we gave the patient neuromuscular blockade, or that paralysis I mentioned before, then we can reverse it at the end of the procedure, so that they're nice and strong when they wake up. And then we, typically extubate the patient or remove the breathing tube and take them to the post-op or post-anesthesia care unit. All right, so that was general anesthesia. Let's move on to neuraxial anesthesia and learn a little bit more about that. So what is neuraxial? So basically it's, 3 different things. You can do a spinal, you can do an epidural, and you can do a combined spinal epidural. So basically a spinal is where we inject local anesthetics. So just like dentists use Novocaine, we use a cousin of that called bupivacaine. And sometimes we use lidocaine as well. And then plus minus an opioid, so like fentanyl, or there's other medicines we can use there as well. We inject that into what's called the intrathecal space, which I'll get to on a slide here in a second. Some advantages: it's quick onset, provides very good pain control for a variety of surgeries. So you can do it for a cesarean section, you can do it for a knee replacement, you can do it for a hip replacement. The list goes on and on. Contrast that with an epidural. So basically, this is a local anesthetic that's injected into the epidural space. So it's a little slightly different spot in the back, which I'll show you here in a second. But it still provides good pain control, basically below the level of wherever you injected it, downward. And then there's something called a combined spinal epidural, where you basically combine these 2 procedures into one procedure. This is, often used for patients who are in labor. So they give, patients, the spinal dose that, provides some more immediate pain control, but then they hook the patient up to an epidural pump, basically meaning that they keep an epidural infusion going, and that's what keeps the patients comfortable throughout the rest of the labor process. And so let's talk a little bit more about the anatomy here. So this is a cutaway of the spine. And so you can see that, at each level of the spine, you have vertebrae, and each vertebrae has a spinous process, which is in the back. So if you've ever looked at someone's back and you see bones sticking out, kind of in a line, that's the spinous process at each level. And so that basically protects the spinal cord here. And so, for epidural anesthesia or spinal anesthesia, we basically want to go in between these spinous processes. And so, usually we're going in the lumbar spine, so at the low back area. We can do an epidural up here in the thoracic spine, but it's just a little bit more complicated, and it's really just for certain procedures that we do that for. Either way, basically for epidural anesthesia, our goal is to get into this space called the epidural space. It's just outside of the spinal canal. And so, there's a lot of nerve endings that go through here and then supply the lower body and up to, whatever level we're at of the spine. And so I'll show you the technique here in a second, but basically we can, get into the epidural space, leave a catheter, a very, very, very small tube there, and give them medicine into that epidural space. Spinal anesthesia, basically we go a step further. So we still go in between the spinous processes of the vertebrae, go through the epidural space, and then go into what's called the intrathecal space. So the spinal cord actually ends around L1, L2, so lumbar 1, lumbar 2, and then essentially it's just a fluid-filled sac below that. So we're not actually, if we're doing a lumbar epidural, we're not actually poking the spinal cord. It's actually just this fluid-filled sac of nerves, and so it allows us to do this because the nerves are actually really resilient, so they'll just kind of move away, and we don't actually hurt the spinal cord itself. That's a huge misconception with epidural anesthesia. But basically if we're doing a spinal anesthetic, we basically inject the medicine into this sac of fluid, the CSF, or cerebral spinal fluid, and then the nerves here get numbed up, and then basically they're supplying the lower half of the body, and that provides really good pain control for labor, and like I said, knee replacements, hip replacements, everything like that. So let's talk about a case real quick. So we have a 32-year-old G1 P0 female. So basically that just means that she has been pregnant once, but doesn't have any, she hasn't finished a pregnancy. So this is her first time. She's at 39 and 5 weeks gestation, and she presents in labor. So she's basically at, term is 37 weeks. So she's, at term. And so, basically at this point, she's, ready to give birth. Her contractions are every 4 minutes, and her pain is 9 out of 10 during the contractions. Her last cervical exam done by the obstetrics and the OB-GYNs showed that she is dilated to 5 centimeters, and her baby is at a station of -2. So basically it's coming down, but it's not quite there. And then, so basically the question from the anesthesia side is, what can we offer her for pain control? So theoretically, we could do a spinal, an epidural, or a combined spinal epidural. In this case, we wouldn't do a spinal, to be honest, because the spinal will only last maybe 2 hours or so, and we can't guarantee that the patient's going to deliver in the next 2 hours. And a spinal is really something we don't really repeat, in the short term. It's something that it's just too risky to do over and over again. So we would do an epidural or a combined spinal epidural. And so it really depends on your practice, your hospital, everything like that. But both would be appropriate options in this case. So like I said, basically a one-time, a spinal is a one-time event in which, I should preface that with saying, you can get multiple spinals over your lifetime. It's not just like a one-time in your life, but we wouldn't repeat it for labor. So for instance, if a patient, comes in and, labor, we wouldn't give them a spinal right away, and then, 4 hours later, give them another spinal. We would just do an epidural. for that. Spinal provides really great pain control for about 90 to 180 minutes, depending on the medications you use and everything like that. And the reason why we wouldn't choose this, like I said, is we don't know that the patient's going to deliver in the next 90 to 180 minutes. So the epidural versus combined spinal epidural debate is really outside the scope of this talk. However, some of the basics. So an epidural alone has a slower onset of action because we basically have to titrate the medicines or basically give small doses until we get a response. And so that can take some time. Combined spinal epidural is much quicker, but it does involve some other risks, including hypotension or low blood pressure, or post-dural puncture headache, which is a specific type of headache that you can get from anytime you go into the intrathecal space. So those are just things to think about. So let's talk a little bit more about epidural technique. There's really two big ways to do this. One is loss of resistance. I would say this is more common. And so basically what you have here is, the patients, here are their spinous processes. If you remember from the previous slides, here's their vertebral body. So basically this is the back and this is the front. The anesthesiologist is behind the patient and they're basically trying to find this space in between the two spinous processes at whatever level that they want to do the epidural at. And they have a syringe with a needle attached to it, and the syringe is filled with saline and often a little bit of air. And so essentially what they do is they go and they go through skin, they go through subcutaneous tissues, and then they go through this in between the spinous processes are ligaments. And so basically you go through the ligaments and you tap on the end of the syringe right here, and basically this is a special syringe that is made of glass. And so essentially what it does is once you are in the right spot, you'll have what's called the loss of resistance. And so what that means is that it will become much easier to basically move the plunger for the syringe inward. And so as you're going through ligament, it's very hard. So basically you tap on it and it doesn't go anywhere. It just kind of recoils. And then once you have loss of resistance, basically the syringe or the plunger will basically go in very easily. And you're in the right spot here in the epidural space. The other option is called hanging drop. So basically you put a little drop of saline at the end of this needle, and you do the same thing. You slowly move through the ligaments until basically this solution that you put on the end is sucked inward, because the epidural space is actually a potential space, meaning that when you inject fluid in it, it expands. But before that, it basically doesn't really exist. So there's a negative pressure here that basically will pull the once we're in the right spot, it will pull the solution into the needle, and that's the right spot. Whether or not you use either one, these techniques, it's really up to you and how you were trained as an anesthesiologist. So, I would say loss of resistance is maybe more common, but you can always use this technique as well. So basically, after the epidural is placed, it's hooked up to a pump that's given, it gives the patient medicine, either continuously or basically every hour on the hour. And then, a lot of hospitals will allow the mother to give themselves a dose of medicine if they need it via basically a button that will be hooked up to the pump. And so if they're feeling extra contraction pain, they can just press the button and it allows them to get extra medicine. So, at times, sometimes, the baby's delivered, soon after the placement of the epidural. Other times, the epidural may be in for 24 hours or so. I've seen both. And so, the other question I always get is, can an epidural be used for a C-section? And the answer is yes, as long as it's functioning properly. You can definitely use a epidural for a C-section, so you don't actually have to go off to sleep or anything like that. Basically, everywhere from the upper abdomen downwards is numb, and the baby can be delivered that way. Then there's always troubleshooting. So you may have to increase the rate of the pump or give additional doses of medicine. If it's really not working, you may have to replace the catheter, but that's, luckily pretty rare. So, all right, let's move on to the third case. And this is in the realm of chronic pain management. So basically, chronic pain is a subspecialty within the world of anesthesia. It's become very popular over the past 5, 10, 15 years or so. So just like the name implies, these anesthesiologists focus on the chronic management of pain, such as low back pain, neuropathic pain from diabetes or other illnesses. There's a lot of interventional procedures, so you can get steroid injections, whether that's into a joint, into the low back, everything like that. They often do radio frequency ablation, so they can find, which nerve might be causing, excessive pain, and then go in there and ablate the nerve that's, causing the pain. And then they can also do nerve blocks as well. There's also pain management physicians that deal with pharmacologic interventions, so non-opioids or opioids. Both of those are options as well. So let's talk about a case in the chronic pain realm. So we have a 43-year-old female coming in for right foot and ankle pain for the past 2 months. You talk to the patient, you find out that she recently dropped a heavy book on her foot. She went to the ER right after the event, and she didn't have any broken bones, but now she's, basically coming to your clinic, and, she says that she followed the recommendations of icing her foot, taking the ibuprofen, everything like that, and it's, getting worse and worse each day. And so she decided to come see you as a pain physician. So you ask her to take off her socks, and this is what you see. So obviously this right foot is swollen. It's, a different color than the left. This is called a mottled appearance. So basically, this kind of, black and blue and red and all different colors, is often called mottled. And then, if you touched it, sometimes, they would just jump off the chair just because it's so, painful and tender. That's also very common. So basically you ask yourself, what could possibly make a patient's foot look like this? So there's something called complex regional pain syndrome, or CRPS. There's 2 types. So basically, if you have a clear cause, it's type 1. If you don't have a clear cause, it's type 2. Some symptoms, excessive pain with even light touch, changes in color or temperature to the affected area. So the foot may feel really warm or really cold. Either one is possible. You can have swelling, which we saw in the picture, changes in skin texture. And so basically you can have, very shiny, thin, hairless, lower extremities or upper extremities. It can happen in both. And so, these are just some of the symptoms and signs that you may be having a case of CRPS. So there's really no diagnosis. It's basically a combination of physical exam and a history of symptoms, and kind of putting all the story together. Sometimes you can use bone scans and X-rays and that sort of thing, but it's not as reliable as X-rays for other conditions. So most of the time, it's just made. The diagnosis is just made on physical exam and history alone. Treatment-wise, many cases resolve on their own. You may need physical therapy or what's called a spinal cord stimulator. Medications, you can use any of these medications listed. There's really no gold standard medication for CRPS because some patients get relief with certain medicines, and then other patients get relief with other medicines. So, all right, so that's it for the cases. Let's touch on what it takes to get to be an anesthesiologist. So 4 years of undergrad, you basically can study whatever you want. If that's world history, if that's English, is that Spanish, is that math? You can do whatever you want, as long as you take the pre-med curriculum and fulfill those requirements to get accepted into medical school. Then you do 4 years of medical school, just like all of your classmates. And then you move on to 4 years of residency. The first year of residency is typically called the internship, or PGY 1 year, so postgraduate year 1. You rotate through different areas of the hospital. You learn how to be a physician, learn how to take care of patients, those sorts of things. And then PGY 2 through 4 are your clinical anesthesia training years. So basically, you're learning how to be an anesthesiologist at this point. So you rotate through different specialties, how to provide general anesthesia, how to do cardiac anesthesia, how to do, anesthesia for labor, everything like that. And then you can go on to a fellowship if you want. So they're 1 year fellowships, each one. So, cardiothoracic, OB, chronic pain, the list goes on and on. But you don't have to. So that's the glorious thing about anesthesia. You can go out and be a great anesthesiologist without a fellowship, contrary to some other fields where you almost need a fellowship to practice. So, if you don't want to do a fellowship, that's totally fine. You can just go out and get a great job and provide, great care to your patients. So I just want to touch on certified registered nurse anesthetists, or CRNAs, because that's, an ever evolving part of the anesthesia field. So basically, these are individuals who go through 4 years of nursing school, typically 1 or more years of critical care nursing after nursing school. And then they do 2 or 3 years of CRNA school. Just depends on the school and how many clinical rotations they have. And then they can go out to practice as a CRNA. And the question I always get is, are they a threat to the field of anesthesia? My answer is always maybe. I think it's too early to tell, because this debate's been around since I was a pre-med. When I was talking to, anesthesia providers back then, they were always saying, oh, the CRNAs are going to take over, the CRNAs are going to take over. And it hasn't happened quite yet. There's been, kind of battles that have been, waged, but at the same time, the war is not over. And so one thing that you could do if you're interested in, anesthesia and being an anesthesiologist is you can do a fellowship to kind of further separate yourself from the CRNAs and give yourself advanced training. It's only 1 year, so it's not that much extra, but at the same time, you can, kind of create that separation. And then the other thing is, I think learning to work with the CRNAs as an anesthesia team is an important concept, and especially in the future. So, there can't be any animosity towards them. You guys are all on the same team. And typically, you're, as an anesthesiologist, you're supervising the CRNAs. So you may be watching 3 to 4 rooms, and there's CRNAs in each room, and you kind of just manage what they're doing, and then you're there for any emergencies that happen. So in summary, anesthesia is 97% chill, 3% complete chaos. So luckily that complete chaos piece doesn't happen very often. And most of the time everything goes very smoothly, and it's pretty straightforward. Some advantages of anesthesia, I would say, are you can carve out a niche if you want. Cardiac, OB, pain management, you can really make it what you want it to be and find a good, job that fits those needs. You don't need a fellowship to practice. You can go straight out from residency. And then, you get to work with different types of physicians and kind of learn what they're thinking about for different surgeries. It's kind of a fun aspect of the field. Some disadvantages, hours can be long, exhausting, stressful at times. There's not much continuity of care, like I mentioned. Depends how you feel about that subject. And then, anesthesiologists are rarely recognized outside of the hospital. Patients recognize the surgeon, they may recognize a nurse, but typically anesthesiologists are not recognized outside the hospital. So if you're looking for something that's, a little bit more, the patients know you, they know who you are, everything like that, anesthesia may not be the best field. And then lastly, the practice can be heavily determined by the hospital or the group of surgeons that you're working with. If they're doing orthopedic surgery only, obviously you're going to be doing orthopedic anesthesia. If they're doing cardiac surgery only, you're going to be doing cardiac anesthesia. It's kind of rare that anesthesiologists don't really bring their own patients into the hospital. They provide a service to whatever surgeons are there. And so you're kind of at the mercy of whatever the surgeons are doing for their practice. So, all right, with that, I would love to open it up to questions, about anesthesia, about, medical school, how to get into medical school, anything like that. Please feel free to ask. So can PAs take a similar route to nurses? So PAs are kind of a separate route. There's a PA school. Similar, requirements. They actually require a lot more. They require a lot more clinical hours before applying to PA school. In terms of anesthesia, we don't really have PAs in anesthesia. It's more, you're either an anesthesiologist or you're a certified registered nurse anesthetist. There are new kind of subfield called anesthesia assistants out there. It's kind of a separate training program. And they have their own schooling, and there's only certain states that allow the anesthesia assistants out there. So if you're speaking specifically to anesthesia, there's really no PA role in the realm of anesthesiologists. That role is basically the CRNA. But in general, PAs have their own kind of program. I think it's 2 to 3 years as well after an undergrad, 4 years, and then you could be a PA. What was your most effective study method that you used in the past for medical school? Yeah, so I think that for me, kind of a combination of things. So reading ahead of time was huge for me. So going into a lecture not knowing what they're talking about just didn't really help me at all. So if I could, most of the time in medical school, they'll give you some sort of book chapter or some other information about the lecture ahead of time. And so what you can do is kind of go read for, that lecture ahead of time. That way, when you go to the lecture, during the first 2 years of medical school, you can, kind of absorb the information better. And then, it usually sticks a little bit better afterwards as well. I was never a huge flashcard person. Some people are really into flashcards. I think it just takes so much time to make them that then you don't have that much time to review them. So if you're really efficient at it, and some people are, flashcards are a great way to study in medical school. It's just, just making them always took too much time for me. And so, I kind of abandoned that idea. One thing you'll find in medical school that, gets incorporated pretty frequently and often is practice questions. So, you need to know how they're going to ask you that information, and it kind of makes you think a little bit more about it versus just answering or just knowing the information. So you need to know how to answer the question, not just know what the textbook says. So practice questions will be key in medical school, and so if you're studying for the MCAT, for instance, then you obviously need to do some practice questions so that how they're going to ask you, or test your knowledge of the material. And then, those practice questions typically have answers and explanations to them. So that's another way to study. But yeah, so basically repetition and, just kind of being engaged and being an active, listener during lectures, definitely help during med school. Do you know of any anesthesiologist program volunteering internship to take in high school or college? It's really just location dependent. So, with COVID, it put a huge damper on, shadowing in general in the hospital setting. We, at my hospital, we basically shut down any non-essential person in terms of they were, working from home. And so, shadowing unfortunately got pushed to the wayside. And I imagine that's very much the case in other institutions as well. So, virtual shadowing is one of the best options at this point. In terms of when things return to more or less normal, it's kind of you kind of just have to reach out in your area, figure out what hospitals there are, and then you can contact there's often anesthesia groups in the area. So if you live in a specific location, you could just Google, anesthesiologist group in Baltimore, for instance, and you can contact the individual group and see if they allow shadowing, and then they could hook you up with maybe the hospital has to okay it or so on and so forth. So there are ways to do it. In terms of an internship, I don't know of anything off the top of my head like that. There's also, if you're really interested in anesthesia, there's also a group out there called FAIR, so the Foundation for Anesthesia Education and Research. They may have some programs out there, that you can get involved in early. I don't know about high school, maybe in college you can get involved in those, that could help. But like I said, a lot of hospitals are not even open to shadowing at the moment just because of the pandemic. So, once things hopefully return to normal by the end of this year, which I'm hoping, then you might be able to get some shadowing in again. All right. I'm not sure if you heard this, but what kinds of extracurriculars did you do in undergrad? Yeah, so as an undergrad, I did kind of what you think about in terms of the basics to cover the checklist, if you will. And I say that because I don't agree with the checklist really anymore. But at the time, that was the only thing I knew. So I did it. So volunteering, I volunteered in the MICU, or the medical intensive care unit, at the local hospital where I was at for undergrad. It's a basic experience in terms of I basically restocked the linens and kind of helped the nurses as needed. But it wasn't, a lot of the patients were sick, they were intubated, they were on ventilators. It wasn't a really good patient interaction type volunteering experience. I also did research in a biochemistry lab. And so, I think that was helpful in a way, but also, I kind of wish I would have done, more interesting things. It was really just to say that I had done research to a certain degree. So I learned, basic lab techniques like Western blots and, growing a culture of E. coli. Like I learned those skills, but, I don't use those anymore. And it was kind of maybe a waste of time. And then the big thing is I worked at the hospital in the department of anesthesia. And so I was an anesthesia technician. So basically I would go in between the operating room or in between the surgeries in the operating room and basically turn over all the equipment for the anesthesiologist. So I made sure that they had all the equipment ready for the next case. I, would help them with any extra equipment they needed for the next case. And, kind of was just an extra pair of hands in that regard. So, that really allowed me to talk to the, the anesthesia residents at that program, and then also the anesthesia attendings and kind of pick their brain as to why they chose anesthesia. So it was really helpful in that regard. And then shadowing, I didn't do a ton of shadowing, maybe like 50, 60 hours total. And so, one thing looking back, I probably should have shadowed more and, kind of had that on my application, but, I was kind of busy with the other things. I didn't have a ton of time to shadow. Let's see what else. I had some human physiology research in there as well, looking at basically exercise science research. And then I did, let's see what else. I did a few other kind of just random, volunteer experiences here and there. But that was, a lot of it. And then what would you say is the hardest part of becoming an anesthesiologist? The hardest part, I don't know. I think just matching into the field, so if you guys have been on social media recently, it was just recently match day for medical students. So, it's a very competitive process. And, being able to match into anesthesiology is, not the easiest field. It's not the hardest field. So it's probably in the middle. But at the same time, it's one thing that, not everyone gets to do, there's not 100% match rate. So, I think just getting into the field, was, definitely, difficult and, took a lot of extracurriculars in medical school and, knowing people and networking and talking to folks and everything like that. And so, more on a day-to-day basis, the hardest part, I guess, is, kind of the unpredictable nature of the field in terms of, you never really know when you're going home each day. And so, you could be done at 2 p.m., you could be done at 8 p.m., you could be done at midnight. You just don't really know. And so, that could be a little challenging on work-life balance. That could be a little challenging on, telling your significant other, hey, I'll be home for dinner tonight, but then you may not be. Those things can be very difficult. So I would say that's, kind of a challenge, that continues. And I guess, now that I think about it, one of the other hard parts that I didn't necessarily have a hard time with was just knowing what anesthesiologists do. I was able to work in the hospital as an undergrad, and I talked to all those folks in anesthesia already. But anesthesia is something that unless you know about it, a lot of medical students even don't get enough exposure to it early enough to apply. So if you're really interested in anesthesia, I really suggest trying to seek it out and try to be able to experience it early, because you may really love it. You don't, I can't predict that you will, but if you do, then you can pursue it. But if you don't like it, that's totally fine as well. It's just, getting that exposure early enough in medical school can be a challenge. And so being able to do that would be hugely beneficial if you're interested in anesthesia at all.
Okay, I think that was the last question, unless someone has a quick last minute question they want to put in the chat real quick. Okay, no, okay, so thank you so much for coming today. I really enjoyed your presentation and I learned a lot about anesthesiology, and Like you said, I hope more people get interested and go into the field. That would
Me
be
too.
amazing. So yeah, thank you so
Of
much
course,
again.
of course. Thanks for having me. Have a good weekend, everyone.
Thank you.